So would it be accurate for me to say that SaRA Health is sort of that bridge in between visits so that there's really no contact loss? You're also that bridge because when clinicians learn about RTM, they're like, oh, cool, one more thing I have to figure out and do. It sounds like you figured that thing out and made it easy for both the patient and provider to keep track of both of those things. Who are you? What do you get to do with SaRA Health?
So my name is Paul Yerhot. I am a practicing physical therapist, so I still see patients several days a week. But with SaRA Health, I'm the Chief Clinical Officer. Yeah. So what does that mean? Well, at SaRA, we are RTM platform, right? So we communicate with patients between visits on behalf of providers. The way we do that is send out daily text messages on behalf of the provider. So you got a new eval, let's say it's a Parkinson's patient, you're going to select Parkinson's patients, and then we're going to send out one daily message on behalf of the provider. So my role primarily is making sure those questions are just as potent as possible. So it's not just going to be about your home program, it's going to be about, are there changes in their shuffling gait, are there tripping hazards, just like different reminders, different nudges, different things to capture. That way, when the provider sees the patient for their next visit, they have just more information.
A picture,
exactly, yeah. So we like to think of like we're enhancing a better first question. So instead of that first question being, how are you,
how's it been?
How's it been? Exactly, your first question can be, hey, on Tuesday, I saw this happen, let's talk about it. You can just kind of jump into more efficient care. So
would it be accurate for me to say that SaRA Health is sort of that bridge in between visits so that there's really no contact loss? You're also that bridge because when clinicians learn about RTM, they're like, oh, cool, one more thing I have to figure out and do. It sounds like you figured that thing out and made it easy for both the patient and provider to keep track of both of those things.
We certainly think so. So from a patient perspective, we're really proud. No login, no URL to remember.
Because it's SMS.
It's all SMS, correct. Yeah, so we have a jitterbug phone at our booth. So, a jitterbug for the elderly population.
That's like the $50 phone that just does, okay, got it.
Yeah. So, the new iPhone, doesn't matter. As long as it takes SMS, you're good to go. So from a patient perspective, it's frictionless. It's not a new platform to learn. It's all very, very familiar. So with that higher adoption than having to download an app, that type of thing. From a provider perspective, you're not keeping track of emails. You're not keeping track of it's a centralized location for all patient comms to come in, and it's directly to the provider too. So it's not a provider, or a patient calling in, getting a secretary. It's directly to the provider.
Now, is it to my phone or a platform that I log into as a provider?
Yeah, great question. It is not your phone. So
I don't want to be. I've given my number out before and then regretted it.
Yeah, me as well. It's not to your phone. We have a centralized dashboard for the provider then to manage all their patients' view. They can reply back. So they are typing into a computer, or they can access on their phone, but it's going to the patient's cell phone. So it's all a central location for the provider. Yep.
And all right, so the prompts.
Yep.
Are they, because we've talked about the structure of what needs to happen for RTM to be properly reimbursed. It's set up automatically, similar we talked to someone like me in marketing, like an email drip campaign. This message is going out every single day, or how does it work? How do you explain to patients, I guess is a better question.
So it is every day. So usually in the afternoon, there's going to be one single question that'll go out to the patient. It's a pretty constrained response, we'll say. So yes, no, did you do your exercise today? Yes, no. Are they too easy? Not hard enough? So we give them a set of options to reply back to. So even the non-tech savvy individual, it's probably going to be less than 60 seconds to reply back.
Good, keep talking.
Not a survey, right? It's just one single question. But yes, it is every day. It is on the weekends. We do have ways of filtering holidays and other things like that, so we're not blowing you up on Christmas. But it is an everyday exchange, which overwhelmingly the patient feedback is very positive. We survey all the patients on our platform, and 75% are very comfortable with the frequency of the messages. 75 or 79% the last I looked are saying the questions are capturing their care or capturing kind of their progress between visits. So overwhelmingly positive reviews from the patients, which is obviously hugely important to us.
So let's go into the weeds a little bit, right? For RTM. The reason you're messaging every day is because I'll say it and you correct me where I'm wrong.
Sure.
You've essentially got to reach a 51% threshold. What the powers that be, the billing powers that be, are saying? Are you connecting more than 50% of the time, or I should say, it's days, right? So if it's 30-day month, you got to do 16 days.
Yep, correct. Yeah. So 30-day windows, right? So enroll a patient today. You're starting a 30-day counter. assuming the patient replies on 16 or more unique days, then they're going to check the box for we call it the engagement code, but they'll check the box, and that will then become a billable code for that 30-day window. And as long as the Planet Care is open, that 30-day window just can repeat. So if you see someone for 6 months, you could fit in technically 6 30-day windows, so you could bill potentially that code for 6 times, assuming they hit that threshold each 30-day window.
And what you're doing is taking the thinking, the tracking, the post-it notes, the scribbled down, notes on my notes app is when that threshold is hit, it's integrated with my billing software, or?
Yep, we're gonna not integrated yet to that level, but we do have an integration that we float on top of most EMRs right now, so you don't have to log on again. You can just click our little button. We're gonna populate your window.
Oh, perfect.
When the billing threshold has been met, we're gonna send you an email just reminding you, letting you know.
This patient has been hit. You can now use this code, and if you're ever audited, you're the proof.
Yep,
you're the receipts.
Exactly. And it's all copy and paste ready. So the provider don't need to look back at how many replies. We have the number of replies. We all have all the required documentation, or all the justification and the documentation just ready to go for them.
And then, how long have you been doing this? And I'll have a follow-up question to that, which is, how's it going? Are you seeing, you've mentioned some stats in terms of people liking the frequency, liking the messaging, thinking it's accurate. Because I'm going to ask a future question too. You get to make a prediction. So how long have you been doing this, and how's it been going?
So SaRA Health as a company has been around since 2016 or so, and so the RTM codes were not in existence at that time. So our primary customers then were first responders, so fire departments and police officers, and we were facilitating like injury prevention programs. So we were doing a very similar thing in the sense that a group would be evaluated, and then we're going to get them the right information, whether it's content from a nutrition perspective or exercises, etc. So that's where we kind of started as a company, and then these codes became a thing in 2022. So we were already very much doing the same thing, texting clients, now patients. So we just pivoted into the RTM space, and so we've officially been facilitating the billing of RTM since January of 2022. I think our first code was billed, was it May? June 7th of 2022, that's kind of the origin story of SaRA and what led us to this current pathway. As far as the second part of your question was, how's it going?
Well, I was going to ask, how's it going in terms of providers and patients? Does doing this help people get better, right? I mean, that might be too early to tell. And then also, do providers like it? Is it easy for them to use? And are they seeing what they should be seeing, which is compliance and revenue?
Yeah, absolutely. So from a patient improvement perspective, right, because we do want to see patient outcomes, the last thing I want to do as a provider, just spam patients with no net result for them. So we have done outcome studies with a couple of groups we're working with, and we've seen improvements in their outcomes higher than like a matched cohort at that same clinic at that same time. So improvements or better photo outcome scores than anticipated when on SaRA versus not on. So we have seen good patient outcomes with that, and we're excited to keep measuring it and tracking that. As far as the providers, we get great feedback from them that they love the connectivity with their patients. More information between visits, like we already mentioned. It brings all their communications to that one location, so they're not searching as much. So overwhelmingly, I would say positive reviews from a lot of the clients we're working with. You brought earlier, providers have a lot that they're doing, right? So another thing to add to their plate is something we're very cognizant of. So our one of our driving forces is just can we eliminate as many friction points as possible? So recently we actually rolled out an AI summary. So the provider doesn't even need to read each of the texts. They can just pop open the summary and get the last week, last month, whatever it is, that they can review those messages. So when they're doing that chart review, it's not a message by message sequence. It is a 30-second or less summary that they can capture.
You were going to copy and paste it into ChatGPT anyway. You guys just skipped the step.
Yeah, exactly. We eliminated you need to hit the copy and paste. Right. Exactly. Yeah.
Bring Steven in here.
Steve, come on in. Yeah. Steven, how you doing? Good to meet you.
Good to meet you.
Come on in. Paul, you can stick around.
I'll here to the side.
So it sounds like and this is what I heard from RTM. I did an episode when RTM first came out with somebody who was just like, here's what it is, here's all the here's the rules that need to be hit. Here are the hurdles that need to be cleared. And at that point, everybody was just like, okay, we don't know how to build that mousetrap yet, and that was 2 years ago. And I heard a lot of therapists say, I'm not doing it. It's not enough juice for that much squeeze. Yep. And it sounds like that's where you positioned yourself in terms of SaRA Health. You're like, we're going to make it easy practical, and repeatable.
Easy, practical, repeatable. I think those are all great words. Also,
If you use it on your website, I just want a nickel.
Yeah, that's fair.
Also, like, we create our business model around figuring out how this works. So one of our values is extreme ownership. And so we created our business model to where you only pay us based on codes you can bill.
Oh,
well,
that's an interesting
Isn't that-
model.
isn't
That's
that the
skin in
way
the
it works?
game.
Isn't
Well,
that
it
the way
should
works for
be.
you, right?
Yeah,
you don't get paid unless
correct.
you treat. So why should we get paid or ask to get paid unless we can give you something to actually bill? So that created an incentive structure that has forced us to really think about how can we optimize and make this work really well. So all the things that come from that, right? The AI summary Paul was just talking about, that came from us looking at our data and seeing, okay, the average 98977, so that's 16 days of data exchange in a 30-day period, goes up almost like on a perfect line based on the number of custom messages that a PT sends, except for this little cluster up here in the top left. We're like, what in the world? Like, what are you doing? So we went and talked to them, and it was like deja vu every time. We're like, I tell my patients I'm probably not going to respond in between visits, but I'm going to use the data when you come back in. And so we saw them have so much success. We're like, okay, perfect. We don't need to try to shift the curve to where every PT is going to take time out of their day to respond to patients. That's just not realistic. Right. But what we can do is help them deliver more value with the data in the follow-up. And boom, right? But if we weren't so focused on how do we increase, especially 98977, like that is the code. That is it. That means your patient's engaging. You are getting good data back from the patient that you're able to use in the visits and to be able to intervene in between. Like, that's the code.
So your goal at SaRA Health is not to get more clients. Your goal is to get more plans of care completed and continued. So when you change the focus, you change what is important to you, and it sounds like what's important to you is aligned to not. Do you have any clients, or do you just have partners? Because those are people you're in the game with all of them. You know what I mean? Like,
that's a
Good question.
It's a good question. I know we view it more as partners, right? Like,
Yeah.
our roadmap has fingerprints from all of the folks that we work with. Like our billing page, Ricky Overton was here earlier from Inspired Physiotherapy. Like, it was his idea. Like, hey, I want this because I want to be able to have good hygiene and make sure these codes are getting billed. Like, okay, then we'll build it for you. Like, so I definitely think it's definitely thought partner at a minimum.
and I mean, 2 years is a long time, but it's also not in terms of like, hey, this brand new thing just came out. We're going to solve it this way. And you're mentioning some innovations, and I do like that word, although I think it's a buzzword right now. We're innovative. But I do like the definition of find a problem that everybody looks at it, says, well, that's not my problem to solve. But the way you're structured, it sounds like you have to solve that problem, because that problem is my partner's problem, which means if I don't solve it, he leaves, she leaves, and then I don't have a problem to solve.
Yep, that's exactly it. So align the incentives. I mean, our healthcare system is a series of incentives.
Correct.
So why not just
Understand the game you're playing and play it well.
Yeah.
All right, so I tipped you off a second ago in terms of future.
Yeah.
This thing's 2 years in. Don't necessarily talk about SaRA Health. We can talk about that, but let's go broader. Like, where's RTM going? Like, what are the things that you guys are just playing around with or hearing and then saying, oh, like, I love the what if. What if we did this? Or what if we did it like this? I mean, you're already showing AI integration, which seems like a layup.
Yep.
But what are the things that we're not even thinking of yet?
I think it's going to be all around there's, I guess, two things I think about is admin burden and killing that ruthlessly executing admin burden, especially on the clinician. So that looks like, how can enrollment be easier? How can you identify what patient type for us specifically to put them into? How to bill it easier. I think a lot of these EMRs are starting to figure out, like, hey, this thing isn't going anywhere, so how can we just drop a bill and be able to make that much more seamless? So I think there's a lot of admin burden that's going to be able to be taken away. The other is the model at a clinic level. And so we've seen a few different models. One, especially for larger groups, like having a centralized admin enroll patients onto SaRA. I think that works really well, but pushing that to the front desk. The headquarters PT model, as we call it.
Which is what?
So it is when a PT or group acts as the first line of defense, if you will. So their job is basically to manage SaRA. because they're able to respond to patients. The engagement ticks way up. It's that 98977, so patients are responding, you're billing that. It's the highest margin code, and you're crushing that. And then they can also add in the phone calls and that to be able to get to patients who need the extra help.
So someone's like mission control. So
Yep.
while
Ooh,
you're
I
over
like
here
that.
mission
Much
control.
better.
While you're over there treating a patient, and you've got a message waiting. We know how it is. If you don't respond in 5 minutes, are you okay? I'm
Yep.
sending out the cavalry.
Yep.
So someone is sort of monitoring that.
Yep.
But this is, correct me if I'm wrong, this is profitable enough where that makes sense to give that person
Yep.
30% of their day. Your job is to watch this dashboard.
Or even 100%.
Yeah, at some point,
Yeah.
when you start to scale, that makes sense.
Yeah, and we see that be really effective. So I think the models that we're going to see come out of this are going to be really interesting, right? But we were discussing this with a very large group last week, and they actually asked the question of, well, what does the model look like, a financial model, if we take away a visit per day, taking away an appointment slot, and just have SaRA run? And so we did the back of the envelope math. Like,
When you mean SaRA, what do you mean by have SaRA run?
Like actually just like get into SaRA for like that.
So a clinician takes off. So you're for 1 hour, your last hour of the day, you're gonna do this.
Yep.
Oh, and
so
what came out of that?
We ran the numbers real quick. Like, okay, let's say they're getting $100 a visit, right? Okay, well, if giving that time to SaRA, so you take that out, so that's $400 a month, right? So maybe that's one a day, maybe it's one a week, whatever it is. Like basically, all you have to do to be able to replace that is be able to build 2 more 98977s across your entire patient population at any given point in time. Let's say you're treating 40 to 50 unique patients. Like you only have to be good for 5% of your patient population, and we know that patients will stay on for longer, and you can extend these plans of care not in a non-ethical or non-clinical way, but like there comes a point where coming in twice a week may not be the most advantageous, right? But as a patient, and I'm a frustrated patient, so I started the company. Like that's why, as a patient, knowing that there's just a tether, there's support for me, even if I'm not coming in, is such a paradigm shift that I love.
Understand what the problem is that you're solving, and some people will say, and we've talked about this before, somewhere the 1 hour long appointment one-on-one was just decided by that's the gold standard. Yeah. What if I don't like that? What if I want to be shown what to do and I want to go back to life?
Yep.
It feels like you get to be more customizable. This is them on their terms and their language.
Yeah. Well, that's it. And we think about it we call it the willingness to resource curve. So it's basically an adaptation of the willingness to pay curve. But as a patient is in high pain, they're also highly willing to resource, right? And so it's not just the cost of the visit; it's driving,
willing to do.
Parking.
Right.
For me personally, it's hey, honey, can you take Michael to daycare because I need to go get PT because I'm in a lot of pain. It's easy to do that. As my pain subsides, so does my willingness to resource, right? They're extremely connected. And so being able to give patients a way to continuing to progress based on where they're at in the willingness to resource curve, that's our more mathematical way of thinking about it. But everyone internally knows that. And they know that patient's going to drop out after this one, they're done. But they don't have to drop out of care completely. Keep that tether.
Right.
Keep that tether.
Ask them what they value, and then see if you can provide that. You got any questions you want to throw in, Tony, as you listen in the background?
So my only question would be for Paul. How did you go from clinical into tech? What brought you into this world?
Yeah, that's a great question. I have to thank a patient for introducing me to Steven,
Really?
actually. Yeah. So I was doing a residency in Minneapolis. Towards the end of my residency, a patient that I ended up getting along with very well, his wife in school with Steven, they made the connection. I've always really enjoyed technology, really enjoy this type of problem solving. So it was just, it's very fortuitous, just right place, right time. And so the relationship started just some long, high level musing phone calls. And then we just enjoyed working together and kind of evolved from there. So yeah, I feel very, very tickled to have landed Midwest Minnesota boy that lands in a tech company is not a story that's often told. So I'm very, very, very thankful to have had that opportunity. Yeah.
Well, it's good, right? Because you understand all the audiences involved, right? So you work for a company that's trying to partner with clinicians to serve patients, and you've been involved in that relationship before, so you can sort of do that thing where sometimes tech companies will run ahead and be like, well, actually, you forgot that. Did you know that little simple thing that in the beginning, I could have told you that. I learned this a lot working at a research lab, which is like, did you ask the patients that you were seeking to provide the technology for if that's even a problem?
Yeah, for sure.
Right? The willingness to resource curve. If someone's like, that's not even my top 20 problems. Like, can you solve these problems?
Yeah.
Those are the problems you want to be innovative for.
But really sexy tech is going to do it, so therefore you're going to,
Because the great math, too, is said, if I get 1/10 of 1% of this market, I'll be a billionaire. It's like, yes, but you're going to get nobody because you're solving a problem. No one. Go into a Facebook group, come to a conference like this, listen to what people bitch about in the hallways. There's your market research. Solve that problem. What we do on the show is called the parting shot. Last thing we do, so you'll both have an opportunity for it. What you can repeat an idea, a sentiment, anything. What's the last thing you'd want to leave with the audience?
The last thing. This is the last thought I had after this last question, but my North Star personally has always been education. I grew up in a family of educators. My mom was a teacher for 35 years, and that's what I love about our product is that we're able to extend education to patients outside of just the clinical setting. So like the right place, right time information. So that I really believe in that. I think that's like very, very high value and also lacking in healthcare. So that's the idea I want to leave, is just right place, right time education and just leading with educating and empowering our patients.
Steven, what's your parting shot?
My parting shot, you can either have a vendor or you can have a partner. And when you have a problem and you have a vendor,
Don't get around to
you
it.
have a problem.
Right.
You have a problem. When you have a partner, we have a problem. And so for those that either haven't taken the leap or are considering going in or even changing what they're doing because they're not seeing the results they'd like to see, if you're not on average seeing an extra $5 to $6 in revenue per visit with no additional time, come talk to us. We'll make it simple for you, and we'll be a partner with you because that's how our business is structured.
I don't know if you noticed, but we've been standing in front of a QR code the entire time. That's just smart. SaRA Health, gentlemen, good luck to you.
Thank you, Jimmy.
You're doing a great thing. Thanks.